Okay, our next speaker is Dr. Kurt Heitman. I have known Dr. Heitman for 20 plus years. Dr. Heitman is an ophthalmologist. He trained in San Antonio, where I did my residency as well. And what can I say about Dr. Heitman other than we're blessed that he's here? As you know, we've talked about somatovisceral involvement, organ system involvement. Not only do people fly in from around the world and around the country to be seen, but one of the reasons they come in is because they want an eye exam from an ophthalmologist that actually understands what RSD is. And this somatovisceral effect, the effects of the eye, we use them exclusively for all of our eye examinations. He has seen more patients with RSD and then ophthalmologic examinations probably than anyone in the world. And so with highest regards and esteem, Dr. Kurt Heitman.
Thank you, Bobby. Well, I appreciate that kind introduction. Actually, the only reason why I'm here is because of Bobby's passion for educating other physicians. I didn't learn about RSD in my residency training, and in fact, you probably won't find it on the radar for most ophthalmology residency training today. We just are not taught about chronic pain syndrome involving the eye, and yet it does exist. And so we're going to move into this and talk about that. First, I do say that I have no financial interest in this talk at all, so I just want to let you know that. But we've already talked about and established the fact of chronic pain being sympathetically mediated, and so I don't want to belabor that point, but I do want to talk about these three things today. Not only is it sympathetically mediated, but it can primarily involve the eye and the ocular adnexa. In addition to that, symptoms from a distal part of the body can spread, we know that, and they can spread to the eye. And so we'll talk about how that can happen. We've already gotten a great description from Dr. Agarwal about the historical perspective of RSD. It wasn't always called RSD. These are just a summary of some of the people that were involved in classifying and defining this problem. More recently, it's been termed chronic regional pain syndrome type 1, and we're learning more about it and defining it and trying to describe it in more detail so that we can better treat patients and better recognize this problem. And again, I don't want to belabor this point. I'm not a specialist in pain management. I am not a physiatrist, so I'll leave that to our colleagues that are experts in that area. But I will mention this: there's a lot of precipitating causes for chronic pain and for RSD. And some of these causes are not things that you would normally recognize, including certain medications and even very minor types of trauma. But one of the causes that I will mention is post-herpetic neuralgia, and that's an area that can involve the eye primarily. And I see a lot of patients with post-herpetic neuralgia that have chronic pain in and around the eye. But what about evidence for primary ocular involvement? Well, there's not a lot of studies out there that have documented reflex sympathetic dystrophy and ocular involvement, but there are some papers that have been written. One was from Japan that documented chronic pain in the eye after retinal surgery. And so the diagnosis of RSD was made, and using the treatment of sympathetic blockade over about a year's period of time, this patient was cured from their chronic pain. But that was direct trauma, surgical trauma to the eye. There's another study that looked at LASIK surgery, laser vision correction surgery, and chronic eye pain after that because of the surgical trauma induced to the corneal nerves. And so we have several instances where there's primary involvement of RSD in the eye. But then we have these other cases, some anecdotal, where we have a case of multiple sclerosis that caused syringomyelia and RSD and Horner's syndrome. And that was an important case because it begins to tie in the idea that sympathetic mediated pain can have some distal effects involving the eye or the ocular adnexa. Another study looked at accommodative dysfunction in patients with RSD, in other words, focusing problems or lack of focusing or spasm of accommodation. That reminds me to mention that sympathetic mediated pain, the sympathetic nervous system is not just hypo or hyper, it's really just dysfunctional. And you can see changes that are associated with hyperactivity or hypoactivity. So it's a dysfunction of the sympathetic nervous system. Dr. Schwartz talked about dystonia, and we've seen case reports of RSD, tonic dystonia, and dry eyes. And so I'd like to just concentrate then on what we can expect to see in patients with RSD, either primary ocular involvement or distal effects. So we're going to look at Horner's syndrome first. As a refresher, Horner's syndrome is a involvement of a blockage or dysfunction of the sympathetic innervation to the eye and the ocular adnexa, causing oops, I'm getting mixed up here, causing ptosis, constriction of the pupil, involvement, pseudomotor function involvement on the ipsilateral side of the face. Sometimes we'll see decreased intraocular pressure, conjunctival injection, and heterochromia. All these are sympathetically mediated events. And just a reminder on the anatomy and the innervation of the sympathetic nervous pathway to the eye and the ocular adnexa. And of course, we start with the hypothalamus. And we have three neurons, basically, and depending upon where the dysfunction occurs, will actually generate different symptoms in and around the eye. Primarily, what we see is a problem with Mueller's muscle, which causes a droopy eyelid, or ptosis. We also see a difference in the size of the pupil. And so then we have a patient that comes in like this, where they have about 2 millimeters of lid droop because they have no innervation to the Mueller's muscle in their upper eyelid here, and they have a smaller pupil versus the contralateral side. And so that's Horner's syndrome. Depending upon, again, where the blockade occurs, we can have a variety of expression of this problem, including dilation of the conjunctival blood vessels. We can see involvement with the ciliary muscle, which would cause problems with accommodation, a weakness in accommodation. We see different size of the pupil. We can see a pseudomotor involvement with the sweat glands of the face. Again, this is a micrograph of the ciliary muscle and ciliary processes. Both of these are innervated by the sympathetic nervous system. The ciliary processes produce aqueous humor, which is involved in a nutritional function in the anterior chamber of the eye. It also helps regulate eye pressure. And so measuring eye pressure, there can be a difference in the eye pressure depending upon how active the ciliary process is at producing aqueous humor. The ciliary muscle is involved in accommodation or focusing, and it changes the lens shape, which is what allows us to focus at different distances. We also see involvement of conjunctival blood vessels and hyperemia, so that if the sympathetic innervation to those blood vessels is interrupted, we see engorgement of the blood vessels. And then involvement of the lacrimal gland. The lacrimal gland is innervated by the sympathetic nervous system, and so if we have an interruption to to that supply, the lacrimal gland is not going to produce tears. If we have a prolonged interruption in the lacrimal gland, we begin to see changes on the cornea, and I'll show another slide later too, with Barré-Liéou syndrome. And here we see blood vessels growing into the cornea from chronic dry eye. So dry eyes can be a serious problem. Another syndrome is Barré-Liéou syndrome. This is where there is cervical trauma, and we have sympathetic damage, or we have sympathetic involvement, and there's different forms of Barré-Liéou syndrome, and the one I am interested in is the ocular form of Barré-Liéou syndrome. And again, with Barré-Liéou syndrome in general, there can be a lot of different symptoms. And I guess my purpose in this talk is to get you to think about chronic pain syndrome and the eye. And that patients that come in that have a variety of complaints, including headaches and dizziness and tinnitus, you need to be thinking about, is there a problem with the sympathetic dysfunction in the cervical area? And so Barré-Liéou syndrome is well documented, and we have several different ocular symptoms with Barré-Liéou syndrome, very much like Horner syndrome, although we don't tend to see an ipsilateral or unilateral involvement like Horner's. So again, it can involve the palpebral muscle, the tear gland, and so on. What we tend to see with Barré-Liéou syndrome is accommodative dysfunction. So we have blurred vision. Oftentimes we see scotomas or blockage in the vision or blank spots in the vision, and that's due to the vasculature of the optic nerve being affected. Again, we see either constriction or dilation of the pupils. We see decreased sensation of the cornea. That causes recalcitrant corneal ulcers because of a lack of the blink reflex and excessive lacrimation. So instead of dry eyes, we see an overproduction of the tears. Here is an example of accommodative spasm where the patient who normally would have good distance vision, everything in the distance is blurred, everything up close is clear because their focusing power is increased abnormally due to accommodative spasm of the lens. All right, we'll skip that. Again, a scotoma or blockage of the vision or blank area of the vision or even visual field loss can be experienced in these patients due to abnormal blood flow to the optic nerve. The optic nerve is nourished by the posterior ciliary artery. Again, this is all under sympathetic innervation. Miosis or mydriasis can occur in these patients. Here's a patient here with, you can see a different size of their pupils. And in fact, in every patient that I see that has a diagnosis of RSD or a sympathetic mediated chronic pain syndrome, I'll do infrared pupillography on them to make sure that I'm under standard conditions measuring their pupils, because we'll see this kind of a difference. That's a recalcitrant corneal ulcer from someone who has decreased sensation of their cornea, causing a decreased blink reflex, and they develop dryness in a location there and an ulcer that's very, very difficult to treat. So in summation, we can see all of these effects from problems with the sympathetic innervation to the eye and the ocular adnexa. In these patients, we have to do a very thorough exam on these patients, including a dilated eye exam. I do what's called cycloplegic refraction, where I paralyze their ability to accommodate or focus to determine what their underlying refractive error is. We do a Schirmer's tear test on these patients. I'll do infrared pupillography to examine their pupils under a standard condition in the dark. And then this is something that I don't do, but would be something to be of interest in the future is to look at thermography in these patients to see what that's showing us. We know that studies have shown that you can show a difference in the corneal temperature in patients with dry eyes. A lot of that is from tear evaporation, but I think from Dr. Brioschi's work too, we ought to be able to see some differences in these patients with thermographic imaging. Now, the treatment for that really is treating the underlying disease. What I can do is sometimes help with spectacle correction and then treating their dry eyes. I can manipulate the size of the pupil pharmacologically. Eyelid surgery is not recommended because oftentimes this is a temporal problem. If the underlying disease is treated effectively, most of these symptoms normalize. So in summary, again, I think we all agree that sympathetically mediated pain syndromes exist, that they can primarily involve the eye, and that we can see distal effects or spread of these symptoms to the eye that would cause sympathetic type symptoms in the eye and the ocular adnexa. And so I appreciate your attention to this. I hope that you will consider this in your patients in the future. Patients that have ocular symptoms may be having symptoms that are related to their chronic pain syndrome. Thank you.